Bismillah ar-Rahman ar-Rahim. Diabetic retinopathy, OCT point of view. The most important scan to obtain in diabetic patient is the volumetric 3D macular scan. This scan consists of 3 concentric rings. The innermost one is the foveal or central subfield ring, which consists of the average foveal thickness. Then there are 2 concentric rings. The parafoveal ring and the perifoveal ring. Each ring consists of 4 regions: 2 superior, inner and outer superior, 2 nasal, inner and outer nasal, 2 inferior, inner and outer inferior, and 2 temporal, inner and outer temporal. This scan consists of 9 regions, which are the 9 heterogeneous regions described by early treatment diabetic retinopathy research group. Why this scan is important? Because it's very important in detecting macular thickening and also in follow-up of its therapy. If we see here, this is the central thickness, not the average foveal thickness. This is the central minimum, which is the minimum thickness in the central ring, and central maximum, which is the maximum thickness in the central ring. This scan consists of many B scans joined together to give you this information. However, it is somewhat small scan, not covering the entire macula. Why? We should take a long line scans, not only in one direction, in all directions of the macula. Why? Because we need peripheral changes in the macula. As in this case, we see it's a partial PVD. There are some epiretinal membrane seen temporally in the macula. Changes extending to the macular periphery, thickening extends to the macular periphery. So it is very important to have full information about the macula, not only about the central macula. It is also important for the instrument used to give you accurate follow-up with tracking system. As in this case, we can see this is the baseline evaluation with its date, follow-up evaluation with another date. This is the thickness described in the baseline evaluation. This is the thickness in the follow-up revisit following treatment, and this is the difference in the thickness between the 2 visits. Another case, we can see here this a more or less stable condition with even below normal central subfield thickness. In follow-up, we can see there is a return of thickening in the macula with increase in the thickness numerically. And this is the difference between the 2 visits. It indicates that there is marked increase in thickness in some region as compared with baseline evaluation. What are the types of macular thickening? Sometimes we can see that there is central sparing thickening, central involving thickening, whatever its cause. How can we describe this as a central involving thickening or central sparing thickening? If it is marked thickening, you can see it clearly with a scan only. But if we are going to discuss it numerically, it depends again on the device that you are using. For example, this device uses measurement below the retinal pigment epithelium to the macular surface. That's why we can add 50 micron to the average scan to describe it normal or abnormal. For example, the fovea is about 300 micron. In comparison with other devices that measure the macular thickness above the retinal pigment epithelium, not below it, you subtract 50 micron from it. For these devices, for this kind of devices, the central subfield thickness is about 300 micron. In the parafoveal ring, it's 350, and in the perifoveal ring, it's about 300 micron. For other devices measuring it above the retinal pigment epithelium, for example, Topcon device, the central macular thickness or central subfield thickness is about 250. In the parafoveal ring, it's 300 micron, and in the perifoveal, it is again 250 micron. So it is important to know what device you are using and what its normative database refers to. Now, if we see here in the thickness ring, we can find that the central subfield thickness is about 300 micron, which is a normal thickness. And the thickening is around it, so this is a central sparing thickening. In this scan, we can see that the central thickness is increased, a little bit increased. However, it is still increased with diffuse spongy thickening involving the macula. In the scan, the thickness is undoubtful. You can see this is a 667 micron in the fovea or central subfield thickness, cystic changes with central serous retinal elevation. Again, this is a patient with central sparing diffuse spongy thickening. Central sparing diffuse spongy thickening. Central sparing diffuse spongy thickening and central sparing diffuse spongy thickening. And what about these small cysts? Is this a cystic thickening? I prefer to describe it as central involving sparing diffuse spongy thickening with small cysts seen around the fovea rather than cystic foveal thickening. Other examples for cases with diffuse spongy thickening. Again, diffuse spongy thickening, but with hard exudates encroaching on the fovea and scattered hyperreflective foci in the vitreous, maybe due to hemorrhage. Central involving diffuse spongy thickening. Central involving diffuse thickening with foveal serous retinal detachment or central serous retinal detachment. These are examples for central involving cystic thickening. Some of them are showing no elevation of the central macula, others showing central serous retinal elevation, tiny elevation in this case. In this patient, we can see there is no problem in the vitreomacular interface. However, the posterior hyaloid is still in place. In this patient, there is partial BVD with residual attachment at the fovea. Total BVD. However, is this patient totally free from vitreomacular interface abnormalities? Well, this depends on residual material from the posterior vitreous that is detached and other factors that will irritate the macular surface like surgery or therapy. Patient with no vitreomacular interface abnormalities. However, we can see here there is a hyperreflective vitreomacular interface. Maybe a problem in the near future or far future, don't know. BVD with vitreous hemorrhage. A patient with tightly adherent posterior vitreous or epiretinal membrane. There is evident tangential traction. So, the macular thickening in this patient, is it purely diabetic or purely tractional detachment? Let's see here. There is equivalent distribution of thickening in all macular layers, from the inner macular layer to the outer layer. Also, there is an inverted contour of the inner foveal region, which we call it ectopic inner foveal tissue. So this is mostly a tangential, not vascular traction. This patient, in contrast, shows combination of both. This is an epiretinal membrane inducing tangential traction on this area of the macula. On the other hand, there is evidence of cystic changes and also vascular leakage, as it is a evident hyperreflective spaces in the outer plexiform layer, which is a specific layer that vascular leakage starts in. Epiretinal membrane inducing tangential traction with ectopic inner foveal tissue and serous elevation and central outer retinal elevation. However, the area temporal to the macula shows both tangential and vascular elements, as this outer plexiform layer shows accumulation of fluid. Anteroposterior contraction of the posterior vitreous can lead to this picture in the center of the macula. So this is an anteroposterior traction with evidence of foveal changes, cystic changes. Also anteroposterior traction of the posterior vitreous with cystic foveal changes and tractional detachment that is threatening the center of the fovea. Epiretinal membrane inducing tangential traction with rupture of the central cyst resulting in both pseudo and lamellar macular holes. Again, epiretinal membrane inducing lamellar macular holes, mostly due to extensive previous laser therapy. Advanced cases of vitreomacular interface abnormalities. Usually these cases will not improve whether with surgery or with injection. Sciatic macular changes are evident. These are not vascular leakage but sciatic changes. Here all the retinal architecture has been lost. Here there are sciatic changes and tractional detachment element, disruption of the architecture of the macula. Again, vitreomacular interface abnormalities can result in tractional retinal detachment. In this case, it is involving the center of the macula. In this case, it is threatening the center of. The recent advance in OCT is OCT angiography, which is very helpful in diabetic retinopathy. Why can't we? And they detect it and project it as a virtual image corresponding to the blood vessels. So on first image give you the blood vessels, but like a black image. However, with motion detection in these blood vessels, they are projected white. This is OCT angiography. What are the disadvantages of OCT angiography? Disadvantages are many disadvantages. However, the most non-desirable disadvantage is that the blood vessels could have motion in it, but less than the device capacity to detect it. So they are projected black while they have motion. So let's see about this patient. This is a patient with diabetic retinopathy, no thickening in the macula, everything is okay. But if you see OCT angio, you will detect fine ischemic changes in the superficial plexus and very evident ischemic changes in the deep vascular plexus. What about patients with more advanced diabetic state? A patient with central involving cystic thickening in both eyes. If we see OCT angiography, we can see the cysts as a black hyporeflective areas with white dots in both superficial and deep capillary plexuses. These dots are the microaneurysms with motion enough to detect by the device. Another patient with central involving cystic thickening in this eye, ischemic macula in the fellow eye with vitreous hemorrhage. But the patient complains of this eye. Why? Because there are many ischemic changes detected both in the superficial and deep capillary plexuses. Another patient with nearly dry macula in the right eye and central involving cystic thickening in the fellow eye. In the eye with central involving cystic thickening, we found that there is a white hyperreflective changes corresponding to the cysts instead of the black areas. Why? Because these cysts contain moving particles, so they were detected by the device as white area instead of black. In patients with NVD and NVE, if they are accessible within the range of imaging of the device, they will appear and can be detected indeed. However, if they are not, you can't detect them. Now, with the advances in OCT angiography, a panoramic view including 120 degrees of the fundus can be obtained. What about the prognostic value of? Before discussing the prognostic value of OCT, it's important to discuss the prognosis as regards the systemic control. 50% of the control of the good prognosis for diabetic patient relies on the systemic control. If you perform a tight control for hemoglobin A1C, blood pressure, anemia, blood lipid level, and cessation of smoking, you performed a great job. Now, what about OCT? Again, first factor is the type of thickening. Central sparing thickening carries better prognosis than central involving diffuse thickening, and lastly, central involving cystic thickening. The presence of vitreomacular interface abnormalities carries less favorable prognosis than patient without vitreomacular interface abnormality. Distortion of the macular layers. If you find interruption of the outer retinal layer, like in this patient, this carries poor prognosis. While in patient with intact outer retinal layer, carries better prognosis. The presence of central serous elevation carries less favorable prognosis. The presence of foveal hard exudate, less favorable prognosis than usual. And also the presence of foveal plaques. By plaques we mean the disruption of the outer retinal layer and replacement of them with the foveal hard exudation. Carries bad prognosis. Disruption of the integrity of the retinal architecture carries bad prognosis. Presence of large degenerative cyst. Even if the cyst flattens with injection, the vision will not be much restored. Also, the choroidal thickness plays an important role in the prognosis. A thin choroid carries less favorable. Marked disruption of the architecture of these retinal layers, foveal plaque of hard exudation, very bad vitreomacular interface. This is a very bad prognostic patient. Similarly in here. What about OCT angiography? Does it have any prognostic factor? Of course. In this patient, we know that this is a patient with papillomacular thinning due to ischemic changes involving the papillomacular bundle. And in this eye, there is central sparing thickening nasal. If we see, the right eye shows ischemic changes, evident ischemic changes in the deep capillary plexus, and the left eye shows minimal ischemic changes in the deep capillary plexus, less evident than the right eye. So the right eye shows less favorable prognosis than the left. It is important to know that in patients with diabetic retinopathy previously treated with laser, never follow him up with fluorescein, because it gives you hyperfluorescent appearance. You can't discriminate whether this hyperfluorescent appearance is due to fluorescein leakage or due to foveal hyperfluorescence secondary to laser therapy, or macular hyperfluorescence staining due to. Also in patients with hypopigmented fundus and in patients with myopia, never diagnose with fluorescein angiography, because there is always hyperfluorescence at the macula due to hypopigmentation. So you cannot discriminate whether this hyperfluorescence is due to leakage or due to thickening. Always see the macula. It is also important to know that if the thickening is marked adjacent to the disc, think of additional factor. Like in this patient, left eye shows thickening that equally distributed along the macula, while in the left eye marked thickening nasally. If you see the long scan, you will find that the disc in this scan and this scan shows marked peripapillary thinning. It is due to marked diabetic papillopathy. In this patient with advanced diabetic retinopathy, with advanced diabetic state and renal complication, we can find that there are bilateral papillary swelling with peripapillary leakage. Autofluorescence can highlight the outer retinal changes like previous laser therapy atrophic changes, but it will not add to the leakage that much. However, it will be a useful adjuvant if you can perform it. Thank you.